Basically, we are going to talk about surgery for diabetes and obesity. Now, you have been hearing a lot about surgery for obesity in last few years in the media. But this is, in addition, we are going to talk about surgery for diabetes. Surgery for diabetes has evolved from surgery for obesity. So initially, we were able to do surgery for obesity, which would reduce the weight and at the same time treat diabetes also. But now we are developing new surgeries by which we can treat diabetes even in those people who are not significantly overweight or who are normal weight people. So primarily, as far as surgery for diabetes is concerned, it's only for type 2 diabetes. I believe most of you who are diabetic would know that there are two types of diabetes type 1 and type 2. Type 1 which starts in children and type 2 which comes in adults. Okay, so it's only for type 2 diabetes. I'll initially speak about obesity and then we'll speak about diabetes because then it will be easier for you to understand how the surgery for diabetes can be done. Few of you might recognize this face. He is from this part of the city only, and I have put this slide right in front so that the message goes loud and clear that we are not talking of cosmetic surgery. Surgery for obesity is a life-saving procedure in large number of patients, and it helps them live longer, live a healthier life. Okay. This gentleman has undergone this surgery when he was 67-year-old, and he was at that time about 123 kgs. And the reason for getting the surgery done was that it was difficult for him to pray. When he bends down, it was difficult to get up from that position. And once he underwent this surgery, after that, he is now about 85 kgs, and he is a tall man. And after that, it has become much easier for him to follow his normal lifestyle. So everybody who is undergoing a surgery need not be getting it done for cosmetic reasons. Everyone has a different reason. Certainly there are few people who get it done for cosmetic reasons. There is no denying that. But majority of them are getting it done for health reasons. So it's important to understand that obese are victims of a disease. They are not the cause of a disease. So it's just like that if somebody is eating sugar, he will become diabetic. It doesn't happen that way. There are people who will become diabetic, and there are people who will continue to eat sugars and still they will never become diabetic. Similarly, in obesity also, you will know so many people who eat a lot and still remain slim, and there are people who eat very less and still keep on putting weight. So it's a disease which has been identified as a disease by World Health Organization, and thus it needs a treatment just beyond diet and exercise. Surgery for obesity started long time back, almost about 50 years back worldwide. We did the first gastric band surgery laparoscopically in this country in 2001 in Mumbai, and also did the first banded gastric bypass in 2003. So there is quite a bit of experience available about bariatric surgery. And this surgery, as I was saying, is a life-saving procedure primarily because of all these benefits. Obesity leads to all these problems, whether it's diabetes, blood pressure, poor heart functions, arthritis of the joints, cholesterol, all this improves. You can see diabetes improves in over 90% patients, blood pressure improves in over 90% patient, heart function improves in over 90% patient, joint pain goes away in over 80% patients, cholesterol and lipids improve in over 90% patient, acidity improves, and many people, they snore at night and they are drowsy during the daytime. It's not that they are lazy, it's just that they are suffering from a disease called sleep apnea. So that sleep apnea gets cured in almost 70 to 90% patients. So these are the benefits besides the weight loss, which must be recognized, that this surgery is able to give you a relief across the board. Just like this gentleman who came to Bombay Hospital for a knee replacement from Jabalpur, and his both knees were so bad because he was 173 kgs when he came to us, and that he could not walk even 3 steps with a walker. And he came here to a very famous orthopedic surgeon who was with the Bombay Hospital at that time, who refused to do a knee replacement, saying that if we do a knee replacement, in a year's time the artificial knees will also give way because you are so heavy. So he was sent to us, we did his surgery. Now he is less than 100 kgs. It's about 4-year-old story, and he has still not got any knee replacement done. He is able to walk 3 kilometers now without even a stick. So no more walker, no more stick, and his mobility from 2 to 3 steps, it has gone to 3 kilometers at a particular time. So though he still remains overweight, but his life has completely changed. He is able to go to his office now. He is able to continue his business. So there are reasons, as I was saying. Now, why surgery for something which is considered a lifestyle problem? Everybody, the patient comes and the relatives come and say, if he eats less or if he goes for a walk with me in the morning, in the evening, he will not need your help. It's a partially correct statement. It's not fully correct because of the very fact that it's a disease, and the very fact that the person can lose weight with dieting and exercising, there is no doubt about it. But usually they lose about 8 to 10% of their weight. But when they are followed up over a period of 5 years, long-term follow-up, almost 100% of them regain weight. This is a scientific study which is mentioned here. So 100% of them regain weight, and that's important. Losing weight is never a problem. Anybody can lose weight. You starve yourself, you work out, you are fasting, one can lose weight. But then weight always comes back. While if with diet and exercise, if we add medicines, they can lose another 10% of their weight, but only 10% of patients are able to maintain it 5 years down the line. So the real issue is weight maintenance. While with surgery, they are able to lose 25 to 50% of their weight, and almost 100% of them are able to maintain it in long term. Alright, 5-year follow-up is 100%, 10-year follow-up, 90% patients are able to maintain their weight. And that's extremely good, because when you are losing weight, you lose both fat and muscle. But when you regain weight, most of the people are gaining only fat. So though the person is becoming heavier, they are becoming physically weaker and weaker every time. So this yo-yo phenomena of losing weight, gaining weight, losing weight, gaining weight must be discontinued, and surgery gives them option to have a long-term weight loss. Then another question people ask me is about risk of surgery, because you do read in the media that this has happened and that has happened. But the scientific data shows, this came from this hospital in US in Connecticut, a very recent study, 2006. What they did was, I'll explain. They had about 1,500 patients who came to their hospital in that period, who were fit for surgery and who were told to undergo surgery. Now 200 of them refused to undergo surgery, because in US they have a very high awareness of surgery. So about 200 of them refused surgery. They followed up all these 1,500 patients who underwent surgery and who refused surgery. And they found that 1 year after their surgery or their follow-up, those who refused surgery, 3% of those died, while only 1% of those who underwent surgery died in first year. While the most surprising data is 5 years down the line, the 20% more people died who did not undergo treatment at the right time. So there is more risk in continuing as an obese than as a person who has undergone surgery. So it's just like, like a heart disease. You have a heart attack. Now you have a choice. You can have a bypass surgery or angioplasty, or you can continue like that, wait for the second heart attack. Now, what is more risky? Certainly there is some amount of risk involved in the heart surgery. But once that surgery is done, your risk of having a second or third heart attack in next 2-3 years is practically gone. So that's important. This is the same kind of results we are seeing in obesity surgery. Now, over here in Bombay Hospital, this is what we follow, this protocol. Do you know what is BMI? BMI is body mass index. Okay, it's very simple. I think you have been given a chart where it shows how do you calculate your BMI. This is weight in kgs divided by height square. Alright, let me explain. If your weight is 100 kgs and your height is, let's say, 5 feet, 1.5 meters. So 100 divided by 1.5 into 1.5 gives you BMI. Now in India, the BMI normal value is 23. So if your BMI is more than 23, you are an overweight person. So those who are BMI 23 to 27, these are the people whom we advise only diet and exercise, because these are the people who can manage their weight with this. Those whose BMI is more than 27 and less than 32.5, these are the people who should be told to have medicines also. There are medicines available and they can lose weight. But those who are BMI is 32.5 and have some kind of disease like diabetes or blood pressure, they are the people, or sleep apnea, they are the people who need surgery. Now this 32.5 is not very high. You see all this in the newspaper that somebody got operated who was 200 kgs or 250 kgs. But that need not be there. This is BMI 33. So you know your height, and if you are 5 feet 8 inches and still under 100 kgs, you can still undergo this surgery. So a 5 feet 8 inches patient with 98 kg weight is 33 BMI and is a candidate for surgery. So it's not necessary that you say, okay, I'm too light, still I am not those 200 kgs, why should I undergo surgery? It all depends on your height. We have somebody who is about 4 feet 8 inches, a nurse in our hospital, and she's 75 kgs and her BMI is 45. So even at 75, she is at a very high risk of having various diseases. Now what is bariatric surgery? Bariatric surgery is not liposuction. We don't remove any fat from your body. So on the day of surgery, there is no weight loss. But weight loss starts from day one. Usually people lose in the first month itself anywhere between 10 to 15 kgs. And then every month 3 to 5 kgs, depending on what surgery has been done. What we do is we reduce the size of the stomach, and so that the person eats less food and feels full, and thus they are eating less calories and are able to lose weight. I'll show you a few procedures. This is the endoscopic procedure. This is not a surgery. Through the mouth, this balloon is pushed inside the stomach. This is the stomach, and then it is inflated like this, and once it is inflated, the tube is withdrawn out from the mouth. So the balloon lies freely in the stomach and it occupies half of the stomach. So the principle is that you are already half full when you are going to have a meal, and you will eat much less. Generally with balloon, people lose about 15 to 25 kgs in 6 months. Balloon has to be removed after 6 months. It cannot survive that environment for more than 7 to 8 months. So the balloon is removed. Again, it is removed through endoscopy. So the endoscope goes through the mouth, punctures the balloon, removes the fluid and pull it out through the mouth. So there is no surgery. After 6 months, what happens? After 6 months, anything can happen. Person, if he is become diet conscious and is able to maintain weight, he may be able to maintain weight. Or person can have a bariatric surgery at that time, or can have another balloon thereafter. The second procedure is gastric band surgery. Now what is gastric band surgery? If you imagine this is the stomach. Stomach typically has about 1 liter capacity. We can eat that much food to get a feeling of fullness. When we say, I had a hearty meal, that means you have a meal where your stomach became absolutely full. You had about 1 to 1.5 liter food, and then there is a stretch on the wall of the stomach, and that is a hearty meal. Okay. Typically, most of the obese people do not eat a hearty meal. They eat much less because they know that they are overweight. After surgery, after any of the surgeries that I'm going to explain, they can have a hearty meal each time because they are able to eat much less, just like this. we put a band around this part of the stomach right here. You can see this is the band. Okay. When the patient eats food, because of the band, there is some amount of restriction of food going ahead because of this narrowing, and thus the food fills up only this part of the stomach, and then there is a stretch on this. So person is eating very less food but feels absolutely full. Okay, so you are eating a very small or a fragment of what you were eating earlier, but you are having a hearty meal, and then the food goes through this through the stomach, which is inside the band, and goes and gets digested normally. So this is how the band works. I'll show you an animation.
Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are placed through the trocars into the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced to the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure.
Now typically patients are mobilized by evening. They are able to go home same day evening, or they can go home next day morning. They are able to have liquids by evening, and almost 99% patients go home within 24 hours after surgery. Now after every procedure I'll show you what are the results. With band, most of the patients lose about 50% of their extra weight. You know, extra weight is very simple. If you know your height, you know what your ideal weight should be. So if you are 30 kg extra or 50 kg extra, whatever it is. So with band, people usually lose about 50% of their extra weight. But some of our patients who have undergone surgery 5-6 years back, they have lost even 90% of their extra weight. So it is not necessary that everything will be done by band. There is a patient's contribution. If they continue to eat low calorie diet, if they continue to exercise, they can lose more weight also. Band is comparatively a very safe procedure. The surgical risk is only 0.05%. Now what does that mean? That means if somebody is undergoing a surgery like a hernia, the surgical risk is 0.05%. It is the same risk. So many of you know somebody who has undergone a hernia surgery, and you know it's comparatively a very safe surgery. Same way band stays at almost that level. Now about diabetes. With band itself, there is 50% of patients have diabetes resolution. Okay, what does resolution means? Resolution means that this person's sugar will remain normal without medicines. 50% patients. Another 30% will have significant control. What does that mean? That means that if this person was taking this much insulin, now he has probably come down on tablets. If he was taking 5 tablets, now he's come down to 1 or 2 tablets. So that kind of significant control can be achieved in another 30% patients. So 80% patients have significant benefit even after a gastric band. And only there is a 10% weight variation in 10 years. So this is important, that with diet and exercise is 100% weight variation even in 5 years. Here, even after 10 years, you have only 10% weight variation. Quickly moving on to the third procedure, which is called sleeve gastrectomy. It's becoming increasingly popular in our country. Sleeve gastrectomy is again done laparoscopically. All the procedures that I'm talking to you are done laparoscopic or keyhole route. So there is no big cut on your stomach. They're tiny cuts. In sleeve gastrectomy, in place of putting a band here as we had shown earlier, we staple the stomach like this, along the length of the stomach, and we remove this white part of the stomach. So after surgery, the patient's stomach becomes like this, only this much. So now the patient again eats less food, there is a stretch on this, and they feel full, okay, just like the band. The advantage of sleeve over band is that there is something which is secreted from here called ghrelin, which makes all of us hungry. So once this part of the stomach is removed, even the hunger goes down. So the person feels less hungry, and then he eats a small amount of food and feels full. So the double advantages. Maybe some of you might have seen this gentleman in the media. He is the heaviest person in this country who has undergone gastric sleeve gastrectomy by us at Wockhardt Hospital. And this fellow, I saw him about 8 days back. In 7.5 months, he has lost 80 kgs. He was about 270 kgs when we have operated him, and now he's about 180 kgs.
Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure.
With sleeve, typically people lose about 70% of their extra weight. With band they lose 50%, with sleeve they lose 70%. And more than that, diabetes gets resolved in 70% patients. That means 70% patients who had diabetes before surgery will not need diabetes medicines after surgery. They will maintain their normal blood sugar levels. And as I said, hunger stimulating hormones, the hormones which makes us hungry, becomes less. Okay. Now last procedure for obesity, and then we will talk about diabetes surgery. This is considered the best procedure for obesity management. This is gastric bypass. Now gastric bypass again done laparoscopically for last 15-16 years, but it is being done as an open procedure from 1967. So we know for more than 40 years what are the kind of results which are available and what can go wrong. So it's considered the gold standard procedure. Now what we do here is that we divide the stomach right here at the top, as you can see. So there is a very small part of stomach which is left here so when food comes, it fills up this part of the stomach, and then there is a stretch on the stomach and the person feels full. And then we join the intestine directly here. So the food, in place of following the normal passage through stomach and this part of the intestine, directly goes into intestine. So it has two advantages. One is that you are eating less and you are feeling full, and then whatever you are eating, 50% of it is not absorbed because it is not traveling through the whole of the intestine. The food is not going through this part of the intestine. It's directly coming here. So whatever food normally gets absorbed from here is not getting absorbed. So it passes in the stools. So the weight loss is faster and it is more long lasting. Okay. Bypass also works in diabetes significantly. I'll show you later, but you must follow this here, because the food is able to reach the last part of the intestine faster. Normally food goes through intestine like this and then here, but here it is able to reach here. So, and this will be used when we will explain to you the diabetes management.
Incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure.
So, as I was explaining, the meal size goes down and there is an element of malabsorption, and thus the patient loses weight. With bypass, they lose around 80% of their extra weight. So it gives maximum weight loss compared to band and sleeve. It does not have a very high surgical risk. Surgical risk stays around 0.5%. But more than that is, the benefit is that diabetes is resolved in over 80% patients, almost 84-85% patients. That means 84% patients will not require medicines for diabetes. After surgery, their sugar levels will remain within normal limits. Okay. And this kind of benefit is not weight related. As you can see from this graph, let's try to explain that this group of patients whose blood sugar before surgery was around 200, within a month of surgery, it dropped down to normal. So, in a month, person can lose 10 kgs. But then, if you lose 10 kgs with the dieting, would your blood sugar become normal? It certainly improves, but it will not become normal. And then, this group of patient, it has remained normal even after 5 years. I'll show you longer follow-up. So, the effect of surgery is direct on diabetes control. It's not related to your weight loss. And that's important to understand, because now we can treat diabetes even in those patients who are normal weight, where we are not inducing any weight loss. Now, when it comes to diabetes, when we move on from obesity to diabetes, obesity had been a problem where there were not many good medicines, and people did not really know how to lose weight. So surgery was still accepted. But when diabetes comes, everybody questions that we have such good medicines available, wide variety of medicines, and we know everything how diabetes happens. Then why should surgery be done? You must understand, there is a blood test called HbA1c, those who are diabetic probably would know, or glycosylated hemoglobin, which gives a 3-monthly blood sugar average. Okay, and this is calculated in terms of values like 6, 7, 8, 9, 12, 14, 15, more. This is the cutoff line, you see this red line. If your HbA1c is above 7, then even if you have a good control of diabetes, you are liable to have blood pressure problems, heart problem, kidney failures, nerve problems leading to loss of limbs and blindness. Okay. Despite best medicines available, despite so many educational seminars and activities done by physicians, almost 50% of patients, this group of patients, they remain above HbA1c 7. You see this 7? They remain above this. Okay. And that is important to understand. And this is Western data, where the medicine affordability, education is very high. If you put this data on Indian population, it would not be 56%, it may be much higher. We don't have the data, it could be 70%. Because so many of our people can't afford medicines, and so many of them are, even those who can't afford, are not well informed about the risk of diabetes. And if you are above 7, as I said, that is the area where all these risks come through, the heart problems and all those issues. And that's why metabolic surgery is a new branch of surgery which claims to treat diabetes. Okay. Now, what is metabolic surgery? Metabolic surgery, as I was saying, evolved from gastric bypass surgery. So if somebody is obese, somebody's BMI is more than 30, I would suggest them a gastric bypass surgery. It was an obesity surgery earlier, now I suggest it as a metabolic surgery, because it takes care of their weight also, it takes care of their diabetes also. But for those who are less than 30 BMI, who are normal weight person or just overweight person, I will suggest ileal transposition surgery. I'll explain what is that. Now with gastric bypass surgery, in our own experience, more than 95% of patients are maintaining normal blood sugar levels without medicines. And this is at par with international data, which I'll show you afterwards. Now what is ileal transposition surgery? Ileal transposition surgery has been developed by a surgeon in Brazil. His name is Dr. De Paula. And he's the only one who has done in 3 digits. He has done about 500 patients in last 6 years. And what he has done, if you are following what I was saying about bypass, that the food reaches the last part of intestine faster in a bypass, because he was bypassing all this. We were bypassing gastric bypass. What he did was, he did not do a bypass. He took a part of the last part of the intestine and shifted it up next to the stomach. So now in place of food reaching the last part of intestine, large part of intestine has come closer to food. So normally it takes about 1 hour, 1.5 hours for food to reach this part of the intestine. But once we have shifted it here, closer to food, the food reaches here in 10 to 15 minutes. So you can see this dark part of the intestine has been translocated here or transpositioned here. That's it. Once this surgery is done, how does it work? This part of the intestine is believed to secrete a hormone called GLP-1, which helps in diabetes control. This hormone has been identified as the probable cause of diabetes control in gastric bypass. Okay. So once this has been shifted here, this hormone is secreted as soon as you sit down when you start a meal. Within 10 minutes, this hormone starts secreting in your blood, and it brings down your blood sugar levels. Okay. Now this GLP-1 is secreted by distal intestine. It is believed to reduce blood glucose level even with severe beta cell damage, even in patients whose pancreas are damaged after having diabetes for a long time. It is believed to stimulate insulin secretion. That means it produces more insulin in your blood. And more than that, it is believed to have a proliferative effect. That means it increases number of your cells in your pancreas. Now, usually in diabetes patients, it is believed that initially you take tablets because your pancreas are working very well. But then gradually your pancreas gets tired of working overtime and the cells get burnt out. Here, after this surgery, probably this will never happen. Or the other way is that patient will probably have a better function of pancreas 5 year, 10 year down the line, even though they have a diabetes. So this is the kind of results that are seen. To show you some of the results, these are the results. This procedure is called sleeve gastrectomy with ileal transposition. These results are from Aureo de Paula from Brazil of his first 32 patients with 1 year follow-up. Now see this, 70% of his patients are maintaining their HbA1c below 6, okay, without medicines, 70%. Another 14% patients are maintaining HbA1c below 7. That means 84% patients are below that red line of 7, where the complications of diabetes start happening, without medicines. And another 15% patients who are not below 7, they are maintaining HbA1c above 7, but they had significant improvement as far as their medicine requirement was concerned. So if they were taking 100 units of insulin, now their insulin requirement may have come down to 10-20 units, or they are on tablets now. So that kind of improvement across the board. And this is the results which were published in international data, and now there are 5 year follow-ups also available. I'll show you, I went to Aureo last year in 2008, early 2008, and then we came back and we had to go through a lot of regulatory approvals in our country, because a new surgery cannot be started unless the regulatory approvals come. And so we could do the first surgery in October, 4th October at Bombay Hospital, and this is the only hospital which has been approved for ileal transposition in this country at the moment. This is a research study, naturally, because it's not a internationally accepted treatment modality. Once our results of our studies will get published and discussed, then it will be accepted by the scientific community. So this has been accepted by Indian Council of Medical Research. I'll show you the results of our patients. All right, I'll try to help you understanding these complicated charts. These are 5 patients, 1, 2, 3, 4, 5. These are their ages, 52 years, 43, 50, 45, 53. These were their weights. So one patient was as light as 67 kg, another was, 2 of them were 75 kgs, and likewise. This is the period of their diabetes. This was 4-year diabetic patient, this was 15 years, 11 years, 4 year, 9 year, like that. 2 of them were on insulin, one for 4 years and another one for 5 years. 3 of them were on tablets. All right. This gentleman who was on the first patient, who was widely reported by the media as the first diabetic to undergo this surgery in our country, he already had retinopathy, that means he had problems in his eyes, and he had kidney problems. This second gentleman, who was on 85 units of insulin a day, became blind in 2005 because of diabetes. He had a diabetic retinopathy, and he had a heart problem, so he had undergone an angiography also in 2005, and he had a kidney failure also. So this is the kind of complications that were seen in only these 2 patients. Other 3 did not have complications, but this lady was on 110 units of insulin. Okay, so patient number 2 and 3 were on the insulin. So just follow, I'll show you the results in the same order. Now their fasting sugars. This patient had fasting sugar before surgery of 215, this patient had 286, this lady on 110 units, despite 110 units of insulin, had fasting sugar of 400 and 222, 160. 1 month after surgery, this is the kind of fasting sugars, 135, 108, 173, 124, look at this, 75. Alright, this lady we have done about 1.5 months back, so this is we don't have 3-month follow-up right now. And then 3 months down the line, 3 months down the line, it is 120, 110, 128, 97. Now this patient, and this patient are off medicines. They are not taking medicines. So, this patient 1, 2 and 4 are off medicine. Patient 3 is still on insulin, but she is from 110 units, she is now on 15 units of insulin. Okay, we are expecting that in another 1 or 2 months she should go off medicine. So this is the kind of results we are seeing as far as fasting sugar is concerned. PP sugar, after meal sugar, has also dropped down from 298 to 180, 389 to 219, 426 to 135, 181 to 113. They are still not normal, but they have gone down significantly, and believing that they are off medicine, this is a significant improvement for 1, 2 and 4. Now HbA1c, for those who understand those who are diabetic, look at this. From 8.5 it has come down to 7.5 in 1 month, from 9 to 6.35, this is without medicines, 11.7 to 8.4, 7.6 to 6.2, 8.1 to 7.3 in 1 month. It's a drastic improvement. Don't look at this is only 1 unit improvement. I'll show you why this is such a drastic improvement. This is not the real value actually, because it gives a 3 months value. So on day 1 of first 3 months, their sugars were very high, 8.5 or whatever, fasting sugar of 400. So the real value will come when we will have the 6-month follow-up, because then their sugars were continuously low, and it will show the same value should become 6 and 6.5 like that. So I think it's a significant improvement. Another issue that's seen here is that their insulin level drops down. Okay, this patient fasting insulin was 42. In a month's time it dropped down to 7.2. This was 10. In a month's time it dropped down to 6.7, and it is 6.7. This lady, which is still on medicine, the insulins have not dropped down. This gentleman was 14, has dropped down to 3. This lady was very high levels of insulin, and it is still high, but the sugars have gone down. So you know, every diabetic have a different kind of disease. But what does it mean? What does reduction of insulin means? It does not mean that your pancreas are not working after surgery. It means your pancreas are getting rest after surgery. Normally in diabetes, initially the insulin is there in the blood, but it is ineffective. It is not working. So the pancreas produces more and more insulin to overcome that ineffectiveness, and ultimately pancreas gets tired and burnt out. Now what is happening here is that their insulin levels have gone down, reflecting that their insulin requirement has gone down. Pancreas are getting rest. So if the pancreas are going to burn out in 2 years from now, they will probably burn out in 10 years or 20 years, or probably never burn out. And that's important to understand. A lot of scientific things that what you need to see this. Now another issue is the kidney functions. This is not a result, just an observation, because it's too early to even claim anything. All our patients have improvement in their creatinine level. Creatinine shows the kidney function. This patient had 3.2, it has dropped down to 1.8. 2.7, 1.4, 1.8, 0.9, 1. That's okay. Now, it has never been documented that kidney functions in a diabetic can ever improve. Diabetic kidney failure is irreversible process. It goes one way only, that it becomes worse and worse. Now, are we seeing a situation where we can claim? We do not know. We'll probably know it 5 years from now, when we will share our experience of 5-year follow-up, because this has never been done in the diabetic management, that you have normal sugar levels continuously for years, and what impact it will have on the kidney functions. So friends, to conclude, now we are in a position to treat type 2 diabetes at any age and at any weight. This is just to give you a cutoff. This is 30 BMI, all right. So those who are, let's say, 5'8" and 89 kgs and above, I would suggest a gastric bypass. Those who are below this, I would suggest a ileal transposition. So it's a very easy watershed line for us, that this weight, because above this weight A bypass gives you benefit of weight loss also. Below this weight you don't need weight loss, and it gives you only diabetes control. Now, ileal transposition has come in last 5 years, but we have long-term follow-up because bypass is being done for 40 years. So what happens to this diabetes control over a period of time? I have just shown you 3 months follow-up. Now there is a lot of published data which says like this: sustained normal blood glucose and insulin in 80 to 100% patients even after 14 years. Okay, so that means it's not a one-time process that I'm showing you something out of the blue and saying, okay, 3 months down the line sugars are controlled, so come on, get operated. No, even after 14 years the sugars are maintained and the insulin levels are maintained. And it is not only for those who are severely diabetic. General perception among masses are that, okay, if diabetes is not controlled and it's not getting controlled with insulin, then you should think about this new procedure. It has been proven with bypass that even those who are early diabetic, there are people whose blood sugar are normal, but if you get an insulin level done, they are high. These are the people who will become diabetic in times to come. So they will not become diabetic. So if somebody in your family is obese child and is pre-diabetic, if he undergoes surgery, he will never become diabetic. It's so important because most of the problems related to health, whether it's heart disease or strokes, brain paralysis or kidney failures, are in diabetics. And it's not only a question of blood sugar control, it's a question of your longevity or lifespan. I'll try to explain this graph, it's a little, but it's very simple. This values below are your HbA1c, 5, 6, 7, 8, 9, 10. Okay. Every 1 unit decrease from 10 to 9, 9 to 8, 8 to 7, whatever you can achieve, there is 20% reduction in diabetes related deaths. So if by medicines, if you are able to control your blood sugar, for every control of HbA1c 1 unit, 20% less deaths. After surgery, we are uniformly providing HbA1c below 7, irrespective of what it was. It could be 14. So there is a 7 unit reduction. Like this lady who told me in the morning that she has 9 HbA1c. So if I can give her less than 7 consistently, it is 2 unit reduction. That means 40% reduction in diabetes related deaths. Significant improvement. So do not, just imagine that it's not a question of inconvenience of taking medicines 3 times or 4 times a day. It's a very small inconvenience. It's also there is an inconvenience of getting blood sugar checked every day or every week or every month, whatever you do. Or there is even an inconvenience of timing your meal to medicines or meal to your medicines to your meals. You can't have a meal at 2 o'clock at night because you're not taking insulin at that time. But 50% of kidney diseases are in those who are diabetic. Most of the heart diseases are in those who are diabetic. Most of the brain strokes are in those who are diabetic. A large number of people in India lose their lower limbs because they have nerve diseases after diabetes. A good number of patients are becoming blind because of diabetes. I have never seen so many blinds in my life as I've seen in last 6 months since he started saying we are treating diabetes. Because now he suddenly finds somebody walking in, 2 people assisting him, and says that we had a diabetic nephropathy, retinopathy, and has become blind 2 years, 3 years back. A lot of people. And then in women, there is a problem called polycystic ovarian disease. Many of you might be aware of this term, where the ovaries have cysts and they have irregular periods. This is a hormonal problem. These people have a condition called insulin resistance. Now it is same like type 2 diabetes, which has insulin resistance. So if after this surgery we are able to reduce insulin resistance, I believe we should be able to reduce the polycystic ovarian disease also. Who knows, 2 years from now we will come again to you and say that we are also treating polycystic ovarian disease via intestinal surgery. And this polycystic ovarian disease also leads to infertility. So all that improves. And then improvement in quality of life. You don't need to worry about what time you are eating and and your traveling and everything becomes easier if you have undergone a surgery for either for obesity or diabetes. Just to show you typically how the patients respond. These are obviously not an issue of diabetes, because diabetes is not seen on the body. This is this lady had come from Dallas about 2 years back, and 6 months down the line she sent me these pictures, and that she has lost about 55 kgs in 6 months. And she had a very interesting story to narrate, that she went to receive her brother at the airport, and brother went by her without recognizing her, and she was so happy that first time in my life I felt good when my brother ignored me, just because she changed so much physically. This lady has undergone surgery very recently in December, and she informed me a day before that she is now 88 kgs. So she has lost 40 kgs. She's from Mumbai itself, and this is the kind of change that you see. In many, if you go through the literature or in internet, the surgery is just the first step. The real weight loss happens after surgery, and that is where you need a lot of support, and that's where the bariatric program of a hospital is tested. It needs physician, it needs dietitian, it needs a lot of psychological support to you. And we have been talking to Dr. Madhu about this meeting. She is the one who provides this support to our patients. On an average, we have about 5 to 6 American patients traveling every month to Mumbai to get this surgery done, and all of them are followed up from here. They don't need to consult a physician locally in US. They are all followed up from here about their diet, about their medicine, about their activity. And in many ways, our program gives better results than even published data, primarily because of this emphasis on the program, on the bariatric support that we give. So friends, thank you very much.